Next, I'd like to introduce Lauren Massimo. Lauren has been working part of our program for about a year and a half. Lauren is fantastic. Any of you guys who come here, will have had contact with Lauren. You'll know how terrific she is. Lauren is a nurse practitioner, a research coordinator in our lab, and Lauren is going to discuss issues related to nursing and end-of-life care.
Oh, thank you. You're way too kind. Thank you.
And let me just say again how instrumental Lauren's been in terms of being able to organize this day. Lauren really did the bulk of the work, and she deserves another round of applause.
Thank you. Oh, geez. Now I'm really going to start blushing. It's great to look out into the crowd and see so many familiar faces. The title of my talk is Nursing and End-of-Life Care. And what I'd like to discuss is the symptoms that you will see as caregivers as the condition progresses, and some interventions that you as carers can put into place to help out. Some objectives that I'd like to cover are, I want to talk about the common symptoms that we see in frontotemporal dementia and associated disorders. I'd like to talk about behavioral interventions and environmental engineering. I'd like to discuss the stages of frontotemporal dementia and some common symptoms that can occur within each stage. And lastly, I'd like to talk about end-of-life care and decisions that you may have to make. So first, I'd like to discuss the symptoms. As previously discussed, the features of FTD include behavioral symptoms, such as disinhibition. We see executive difficulty, so difficulty with planning and organizing. We see in aphasia, there's speech and language comprehension. And in CBD, we see visual-spatial difficulty. Some of the behavioral challenges that caregivers face are things like disinhibition. Patients will just walk up to a stranger on the corner and start talking to them. Or patients will just start telling sexually inappropriate jokes to their teenage daughters. We see aggression, or patients get easily agitated, and it's really unprovoked. We see ritualistic behavior, so eating certain foods only at certain times. We see apathy or lack of emotion. We also see that it's difficult to get the patients motivated. And lastly, I think the thing that's really hard that I hear from the caregivers is that the lack of insight that, these patients really just don't understand that they're really causing distress. Why? What am I doing wrong? There's nothing wrong there. So it's really distressful. Some interventions that you as caregivers can put into place to help out with some of the behavioral problems are things like avoiding crowded places. So crowded places really provoke, there's lots of stimuli there, and they can really provoke unwanted behavior. So go off hours, go to an early bird special, and less people will be there. It's less chance of the behavior happening. Provide a daily schedule for your loved one. Keep them busy. This will limit the chance that they're going to go off and get themselves into trouble. Control access to things that are problematic. So for patients that are hypersexual, get rid of the Victoria's Secret magazines. We know that carbohydrates are a big problem a lot of times, sugary foods. So don't bring it into the house or hide it. We see impairment in executive function, so things like difficulty with planning and organizing, not being able to manage a checkbook, and bouncing checks, or simple things like making a grocery list and then going to the grocery store and getting the right items, the items that were actually on the list. We see poor judgment. I was just talking to a family member the other day whose mother has FTD, and she was saying how her mom was just walking out into the middle of the street. This could be quite dangerous. And inattention, it really, I hear that, till you talk to the patient with FTD, and they're not paying attention to you. They're looking here, there, and everywhere, but really where they should be. Some interventions that can help out with executive difficulty are things like structure the environment. So constrained choice, I think Dr. Grossman spoke briefly about this earlier, but structure the environment, give them two choices. So instead of saying, what do you want for dinner, and being very vague about it, give them a choice. Do you want a hamburger or would you like a pizza? Make lists and check off each step as they go through. Divide activities into simpler tasks. So things like making the bed. Instead of saying, go make the bed, really you put the sheet on first, then put the pillowcases on, etc. If patients are distractibility, really redirecting them to task. And individualize your strategy. The strategies that may work for one caregiver may not work for all caregivers. Speech and language difficulty. We know that patients with FTD, they have trouble with their speech and language. Some problems can involve the comprehension of speech and written words, such that patients don't understand what they're reading, so they don't understand reading the newspaper, or they used to love to read books, but now they can't do that anymore because they don't understand what they're reading. The same problem can also affect the ability to produce language and can involve in difficulty with naming and object recognition. In the progressive non-fluent aphasic population, we see that there's a problem with the motor aspect of speech. And this may affect the ability to make their mouth move as they want it to produce a speech. This is called apraxia. So some interventions to help out with speech difficulty are things like speak slowly and really give your loved one time to process what you're saying. Use shorter sentences. We have a tendency in our everyday language to use lots of adjectives and other sentence modifiers, as I'm doing now. And it's just be direct and to the point. Speak in context. What I mean by this is, if you're talking about having dinner and you're in the living room, bring that conversation into the kitchen. Use lots of gestures. Speech therapy can be helpful in a few ways. So speech therapists can teach patients, they can practice with them naming familiar objects that are going to be useful for them. So developing a core set of objects, not trying to teach them new things or new things to learn, but a core set of things to go over, like that they're going to need later on in life, like toilet or toothbrush, things like that. Computer-assisted devices are available. Some of them are available online. Some are available through medical supply companies. In the state of Pennsylvania, they will actually loan out computers for months at a time with devices installed on them, or programs installed on them that will do picture to words or text to words. And if you cannot read that small writing, you can see me afterwards and I can give you the link. And lastly, picture cards is demonstrated up there, having the word on one side and then the picture on the other side. We know that patients with corticobasal degeneration have problems, visual-spatial impairment, so difficulty locating objects in space, so they can't find things even though they're right underneath their nose. They don't understand what they see. They have trouble using things like knives and forks, and they have difficulty with dressing. Some interventions to help out with visual-spatial impairment are things like mark the problem areas. The stairs are a biggie, especially. So what we tell our patients is to mark each stair off with bright-colored masking tape, and this really clearly defines each stair. It's also helpful to put the masking tape or the bright colored tape along the banister as well. Minimize falls. This is important. Falls is a big risk in this population. So get rid of the throw rugs and the toys and the clutter on the floor. Physical therapy can be helpful to maintain joint mobility and to limit contractures, which can be quite painful. I know that a caregiver that I was talking to, he has his wife puts in an exercise video at home and has her work with the exercise video at home, and that really helps to build her strength and to keep her strength. And occupational therapy can help with some orthotic devices. So now I'd like to discuss the stages of FTD. We stage disease severity in terms of how much the patient can do on their own. So we see here that the mild stage is the longest stage. And Dr. Grossman briefly explained before, we think that the reason is because of compensatory mechanisms. In the mild stage, we see some cognitive problems. As we get to the moderate stage, the patient is relying more upon the caregiver for their needs. And in the severe stage, the patient needs all of their care, all their activities of daily living from the caregiver for survival. In the mild stage, we can see things like poor judgment, limited motivation. It really takes a lot to get these guys going. Hesitant speech, difficulty understanding complex sentences. Sometimes the patients will just sit there and just look at you with this puzzled look on their face. And we see that they talk around ideas because they can't find the words that they want to use. In the moderate stage, we see more assistance with activities of daily living. We see incontinence, especially urinary incontinence. We see confusion, which leads to wandering behavior. And hallucinations and delusions may be present. In the severe stage, we see complete assistance with activities of daily living. Sometimes we see that the patients can't recognize themselves or their caregivers who they've known for years and years. There's difficulty swallowing, which is called dysphagia, and this sometimes results in things like aspiration pneumonia, which I'll talk about in a little bit. We see infections like urinary tract infections a lot in this stage. So there's frequent calls to the office to say something's not right, and it ends up being infection. Patients at this stage also become bed or chair bound. They really lose the ability to ambulate. And we see limited communication, such as mutism. The prognosis really varies. And we touched a little bit on this in Dr. Grossman's speech this morning. But the duration is 2 to 15 years. That's pretty large. The average is about 88 months. Which is a little over 7 years after symptom onset. So I'd like to talk now about end of life and some things that you as caregivers want to think about. Mobility becomes a problem in the severe stage. Things like pressure ulcers or bed sores occur because patients don't shift their weight on their own. They're just stationary. This can happen in the course of just a few hours. They can develop what we call stage 1 pressure ulcer. Another factor that goes into developing pressure ulcers is incontinence. Incontinence creates a moisture environment, which is another risk for pressure ulcers. We see falls frequently because of the reduced strength in the legs. Constipation is a problem. If the patients aren't moving around as much, the bowels also slow down, and the result is constipation. It could be quite a problem. And blood clots in the legs because if the patients, again, are not moving around and not mobile, the blood is not circulating and it slows down in the legs, which can cause blood clots. The blood clots, unfortunately, can travel to the lungs, which is called a pulmonary embolus, and we see that this is a cause of death sometimes. So interventions to promote mobility are things like, again, physical therapy. Range of motion exercises are great. Physical therapists will teach caregivers how to administer range of motion exercises, and then you as caregivers can administer this a few times a day to really keep the joints mobile. Reposition, so repositioning your loved one every few hours if they're sitting in a chair, and even while they're sleeping, they still need to be repositioned, shifting their weight off of that after that area every few hours. And again, deconditioning or weakness makes mobility difficult, so it's important to do to get the physical therapy, to get legs, strengthening exercises in there. Okay, I want to talk a little bit about swallowing. So what happens in the end stage is that we see the swallowing mechanism slows down. Because it slows down, thin liquids can spill over into the airway, and this has caused an aspiration pneumonia. Normally, when we swallow, the food goes down into the esophagus and then goes down into the stomach. But when there's liquids that get down into the trachea, this goes down into the lungs and causes an aspiration pneumonia. It's really pretty difficult to treat. We see this also as a cause of death. This is an important point, is that aspiration can be silent. Normally, if you or I were to take a sip, and it went down the wrong pipe, we would be able to cough it and expel it from, our airway, but that's not true in end stage. The patients really lack that mechanism of being able to expel, foods and liquids on their own. It really is difficult. So swallowing studies can be important, especially for if you think that the patient's aspirating, and like I said, it could be silent, and so swallowing studies can confirm an aspiration or that they're aspirating. Mechanically ground foods and thickened liquids are helpful because these foods take longer to swallow, and it really accommodates the slower swallow. Avoid straws. So the straws bypass the lips and puts the liquid right into the back of the throat, and that makes it really easy to aspirate. Crush medications and give it an applesauce. I find that this is helpful a lot. But check with your pharmacist first. Some medicines, like sustained release, they may say SR or extended release, XR, on the pill package. They can't be crushed, but check with your pharmacist first about crushing the medicines. If you can't crush the medicines, talk to your doctor about maybe prescribing like a liquid medicine or something along those lines. And no talking while eating. And we say this because while you're talking, your airway's open. And again, if your loved one is talking while he or she is eating, it provides opportunity, again, to go down into the trachea. In a large review of tube feeding studies by some experts at Johns Hopkins University, they found that there was no difference in survival between those with tube feedings and those who did not have tube feedings. In fact, they found that there was complications that occurred frequently after surgery, things like infection. And aspiration pneumonia can still occur because it does not prevent the aspiration of saliva. We find frequently that a tube feed can actually cause agitation in patients with FTD, and sometimes it may get yanked. Some complications that are associated with incontinence, urinary tract infections, and subsequent sepsis or an overwhelming infection in the body. And pressure ulcers, again, can be infected if there is bowel or bladder incontinence. So interventions to help out, avoid caffeine, be watchful. And what I mean by this is be watchful of symptoms like agitation or confusion, delirium. These are often signs that there is an underlying infection. In this case, you want to obtain a urine specimen, talk to your primary care provider, collect a urine specimen, take it to the office, and they can test it right in the office. And this can be treated with antibiotics. Avoid water pills. This is often used to treat, diuretics are often used to treat high blood pressure. There are other medications that can be used to treat high blood pressure. It does not have to be a diuretic medication. So talk to your primary care or your family physician about maybe switching over the class of medications that's being used. And develop a toileting schedule every 2 or 3 hours, bringing your loved one into the restroom. Another thing that I want to point out here, especially when mobility becomes a problem, is think about installing grab bars next to the toilet to make it easier. Or get a commode and place it next, a commode which is a portable potty, and placing that next to the bed so that your loved one does not have to go all the way into the bathroom and make that travel. I want to talk a little bit about advanced planning. It's important to have conversations about, with your loved one in the mild stages about what they want for their care and where they want. Especially, do they want a tube feed? Do they want to be treated with blood transfusions? And do they want CPR? How aggressive do they want their care to be? Discuss these treatment options with your family. And encourage a meeting with family and the treatment team. Dr. Grossman and I, really feel that, our philosophy is to not only take care of the patient, but that we take care of the caregiver as well. So really get your family involved. And lastly, I'd like to talk about brain donation programs. Brain donation programs can be beneficial in a few ways. Number one, it provides a definitive diagnosis. As you've heard today, that neurologists may be wrong. It may not be the right diagnosis. And we can only say with 100% assurity what the condition was that affected your loved one until a direct examination. I find that by talking to families who've participated in programs, that it provides them with the confidence that they know they've done everything and they did the right thing. Donating, there's also anatomical reports that are generated. And this really relates your observations directly to the disease process. So we look at things, I was talking to a caregiver a few weeks ago who had, whose dad was pretty disinhibited. And when they got a report, it showed that, that the area of the brain that was affected was the part of the brain responsible for disinhibition. And so, there is a physiologic problem there, not just because they wanted to go off and talk to strangers and do crazy things, but there is an actual problem. And it gives you the opportunity to discuss your results with your provider. Importantly, it really advances medical research. The recent discoveries of progranulin and TDP-43 are really because of patients and families who are dedicated to the research and, that have taken part in a brain donation program. So in conclusion, I'd like to say that there's lots of things that you as caregivers can do different interventions that you can do for different symptoms. The symptoms change over time as patients progress through the stages. You want to develop an individualized plan of care. What works for, like I said, one caregiver may not work for all. Work with your family. I think Lisa discussed this as well. Share your care. And plan ahead, especially in the early stages. It's important to talk about these kinds of issues with your loved one. And lastly, I'd like to thank Dr. Grossman, and I'd like to thank the guys in Dr. Grossman's lab, and more importantly, I'd like to thank the caregivers from whom I've learned so much from. So truly, thank you.